Hello and welcome everyone. Today we'll be discussing regarding the serotonin syndrome. Serotonin syndrome is a potentially serious, often unrecognized condition caused by increased serotonin activity in the central and peripheral nervous system. It exists on a spectrum from mild to even life-threatening. Early recognition and management is critical to prevent the morbidity and the mortality. Serotonin toxicity reflects the spectrum better than a syndrome. The causes of serotonin syndrome is invariably caused by drugs that increase serotonin levels in the brain. This can occur with therapeutic doses of serotonergic agents, drug interaction, particularly when combining multiple serotonergic drugs, intentional or maybe unintentional overdose, overlapping transitions between serotonergic medications without adequate washout periods. Now, common drugs which can be involved are the most common being the selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, monoamine oxidase inhibitors, TCAs, opioids, stimulants like amphetamine, cocaine, MDMA, lithium, certain antibiotics like linezolid, herbal supplements like St. John's wort. The combination of monoamine oxidase inhibitors with SSRI and SNRI and other MAO carrying agents, the highest risk of severe serotonin syndrome. The incidence of serotonin syndrome is difficult to determine precisely because there are various factors playing over here. There is a clear underreporting because many of the cases are mild and which are frequently overlooked both by the patient as well as the doctors. There is a general lack of awareness. A significant portion of the physicians, including general practitioners and even some specialists, have limited familiarity with the serotonin syndrome as a clinical entity and its diagnostic criteria. And even in the diagnostic criteria, there are a lot of criterias, and there is no universally agreed upon criteria as of now. Misdiagnosis, non-specific prodrome and protein manifestations of the serotonin syndrome can lead to misdiagnosis with symptoms being attributed to other causes like infection, anxiety, or metabolic disorders. In severe cases, it may be mistaken for neuroleptic malignant syndrome. Cases resulting in hospitalization and death are rare. Mild toxicity is likely underreported. In US, the number of ingestions of SSRIs associated with moderate to major effects reported to Poison Control Center increased from 7,000 to 8,500 from 2002 to 2005. The Toxic Exposure Surveillance System reported 54,000 incidents of exposures to SSRI in 2016, with 102 deaths, 57,000 exposures in 2017, with a small percentage resulting in death, that is 0.009% in 2017. Large case series suggest that moderate serotonin syndrome occurs in 15% of poisoning with SSRIs. One study estimates the incidence of serotonin syndrome between zero point 0.9 to 2.3 per thousand individuals exposed to at least one serotonergic agent in 2013 using the US insurance claims database. Another US database keeps the incidence around 0.07 to 0.19%. The post-marketing surveillance study identified an incidence of zero point 0.4 case per thousand patient months with patients taking nefozodone. The serotonin syndrome is thought to occur in approximately 14 to 16% of patients with overdose on SSRIs. The clinical features, the triad of serotonin syndrome. Patients typically present with a combination of the following signs and symptoms, often develop rapidly within hours to 1 day of the dose increase or addition of a serotonergic agent. So the triad is neuromuscular abnormality, which includes clonus, hyperreflexia, hypertonia, tremor, myoclonus, and increased motor activity and agitation. Apart from this, you will find the second part, that is the autonomic dysfunction, which is seen as tachycardia, hypertension, diaphoresis, dilated pupils, hyperthermia, GI symptoms like diarrhea, nausea, and vomiting. Finally, you have the altered mental status, where you find agitation, confusion, anxiety, disorientation. In severe cases, you can even find delirium. So, this is the triad of serotonin syndrome that you must keep in mind: the neuromuscular symptoms, the autonomic dysfunction, and the altered mental status. So, how do we make the diagnosis? There have been three major criteria. The first is the Sternberg's criteria, which was proposed in 1991. This criteria was based on three or more and described symptoms in 38 cases of serotonin syndrome. The inclusion here is coincidence with addition and increased dose of certain serotonergic agents within an established therapeutic regimen, excluding other etiologies like infection, substance abuse, and a neuroleptic agent has not started or at is an increased dose before the onset of signs and symptoms. Now, what are these signs and symptoms? Three or more must be present, that is mental status change, agitation, myoclonus, hyperreflexia, diaphoresis, tremor, shivering, fever, though often implies hypothermia, incoordination, sometimes referred to as uncoordination, and diarrhea. So the limitations, as you can see, is that these criteria are considered to have potential low specificity, as symptoms like confusion, agitation, fever, they can be found in other medical conditions as well, possibly leading to false positives. And they also require the absence of a neuroleptic agent, which can be problematic because this was an old time when SSRI was not commonly used, but then second generation antipsychotics, they do have some kind of serotonergic activity. So the reason why we're leaving out the neuroleptic agents is because we know there is a syndrome called neuroleptic malignant syndrome. So it was considered that if the patient was on neuroleptics, then possibly the syndrome that we're dealing with is neuroleptic malignant syndrome and not serotonin syndrome. So it was used as an exclusion criteria. To differentiate between the two, the onset is rapid in the serotonin syndrome, slow over 1 to 2 days, 3 days, or even weeks of the neuroleptic agent. The common causative agents, as we have already discussed, is the serotonergic agents, and dopaminergic antagonists are used for the neuroleptia. That these are the old generation. The new generation also have serotonergic effects. Neuromuscular findings are hyperreflexia clonus in the neuroleptic. It is led by rigidity, hyporeflexia, and bradykinesia. Mental status, here you will find more agitation, there you will find more stupor and mutism. Autonomic dysfunction are more or less similar. Pupils are dilated here, normal in neuroleptic. Clonus is present here and usually absent in the neuroleptic syndrome. Reflexes, again, hyperreflection, hyporeflexia. Muscle tone is more rigid in the neuroleptic. Fever may be present, but here it is extremely high. Creatine kinase, mild to moderate elevation. Here it is markedly elevated because of the severe rigidity and temperature. So there is an increased muscle breakdown. The onset after drug withdrawal is unlikely in the SSRI, while it is possible with the neuroleptics. So treatment is stopping the agent, supportive care, benzodiazepines. Here it is stopping the neuroleptic, supportive care, dantrolene, and bromocriptine. So the other criteria was Radomski, a similar criteria developed in 2000 that was built upon the Sternberg's criteria, expanding with further cases that were included. They suggested dividing the symptoms into major and minor. In this, they included almost a similar type of thing, coincidence of the serotonergic agent and the development of four major or three major with two minor symptoms. Other etiologies to be ruled out as before, and neuroleptic agents should not be a part of the treatment. The major symptoms being agitation, myoclonus, hyperreflexia, diaphoresis, and tremor. Minor symptoms being on altered consciousness, restlessness, elevated mood, insomnia, coma, uncoordination, dilated pupil, shivering, akathisia, rigidity, fever, tachycardia, tachypnea, dyspnea, diarrhea, hyper and hypotension, and sweating. The criteria that we use currently is the Hunter serotonin toxicity criteria. It was proposed in 2003. The criteria was derived from 437 cases, and this was more pertinent because it is linked with the serotonin reuptake. And this criteria were currently the most commonly used and recommended for clinical practice. In this, you need the presence of a serotonergic agent and one of the following, that is spontaneous clonus, inducible clonus, ocular clonus, inducible clonus or ocular clonus or hypertonia or temperature more than 100.4 degrees Fahrenheit. Tremor and hyperreflexia can also be there. So this table basically summarizes all the three criterias. You can pause and see it in the details. It describes all the sensitivity, specificity, and which is being used and why. Coming to the differential diagnosis, neuroleptic malignant syndrome, as we have already discussed, is the most common differential, which has more slower onset associated with dopaminergic agents characterized by led by rigidity, bradyceflesia, and higher fever. Clonus is typically absent. Anticholinergic poisoning, which is patient present with flushing, anhidrosis, anhidrotic hyperthermia, mydriasis, urinary retention, decreased bowel movement, normal reflex, and muscle tone. In this, other considerations like CNS infection, metabolic disturbances, withdrawal symptoms, and malignant hyperthermia must be kept in mind. Management. The first and the most crucial step is immediate discontinuation of all serotonergic medication. Supportive care should include monitoring the vitals, provide intravenous fluids and electrolytes, oxygen if needed. Cooling requirement is there. Antipyretics are generally ineffective, so physical cooling is more done. Sedation with benzodiazepines to control the agitation, anxiety. In severe cases, consider serotonergic antagonists like cyproheptadine, and which can be given orally or by a nasogastric tube. Neuromuscular block paralysis. Prevention, educate prescriber and patient about the risk of serotonin syndrome, the causative agent, and the early signs and symptoms. Obtain a thorough medical history, including over the counter medications, herbal supplements, illicit drug use, and be vigilant about polypharmacy. Use the lowest effective dose of serotonergic medication. When transitioning between serotonergic, observe the appropriate washout period. Exercise caution when combining MAOI inhibitors with this. Consider the potential of interaction with drugs that may have an off-target serotonergic activity. Electronic prescribed system helps here. Follow up with patients a few days after starting a new serotonergic drug is vital. Reassess the ongoing need for serotonergic agents. So the take-home message is serotonin syndrome is a medical emergency caused by excessive serotonergic activity and can range from mild to life-threatening condition. Early recognition is crucial. Look for the triad, that is neuromuscular abnormality, autonomic dysfunction, or orphan mental status, especially in patients who are on serotonergic agents. Closeness and hyperreflexia are key. They help to differentiate from the mimickers like neuroleptic malignant syndrome. Immediate discontinuation is important. Supportive care is vital. In severe cases, go for serotonergic antagonists and advanced supportive care. Prevention, uh, proper prescribing, vigilance, avoiding polypharmacy, combination therapy, appropriate washout period, and patient education is vital. And clinicians should maintain a high index of suspicion, especially when the criteria like Hunter are not fully met, especially if the patient is having polypharmacy. Thank you for your patience.